Health disparities significantly impact the deaf and hard of hearing community, particularly in the wake of the COVID-19 pandemic. Lack of access to health information for deaf patients and lack of provider training about issues faced by deaf individuals contribute to these disparities. Mask mandates and visitor restrictions have disproportionately affected deaf patients, making it even more important for medical providers to establish trust and understanding with this population. This video will provide insights into the unique experiences and challenges faced by deaf patients and equip medical providers with tools and knowledge to better serve their deaf and hard of hearing patients.
I don't often see patients who are deaf. I'm not really sure how to interact with them. I don't want to do something wrong or upset anyone.
Waiting rooms have been crowded, especially with the pandemic. Talking with deaf patients and making sure they understand takes longer than conversations with typical patients, which makes me a bit anxious. Sometimes I feel like I need to move on to other patients so everyone can be seen and reduce the long wait times.
If the deaf patient and I are writing notes back and forth, it takes a long time. My hand gets cramped. I find myself tempted to abbreviate things or only write strictly necessary information in order to save time. We both leave the appointment feeling dissatisfied.
So they said my wife could interpret, but this was an emergency and I need my spouse to be an emotional supporter. Just like everyone else's spouse, it's hard for them to take on the interpreter role when they have their own emotion related to what's happening to me too. I feel like that they are taking advantage of my spouse.
When deaf patients come in, sometimes I don't know how to best communicate or even what to do. I feel like a deer in the headlights sometimes. I'm afraid I'll do something wrong. I've never been trained on this, and I don't want to cause a lawsuit.
Without being equipped with the proper knowledge and training to serve deaf patients, both medical providers and deaf patients suffer. This video will provide an introduction to terminology, deaf culture, communication preferences, and strategies to create positive experiences for both parties. This information is based off of a focus group study that we did of deaf patients in Utah and tells the results of what we have heard from deaf patients.
When I say deaf culture, I do mean an actual culture with its own history and language and customs. The hearing world, you don't always make eye contact when you're talking to somebody. You might have an earbud in your ear and be a little bit distracted. And you might not always do lots of other things, frankly. It's a very long list. And when you get into deaf culture, you are looking at someone. If you don't look at them, it's the equivalent of ignoring them. If you say, never mind, when they ask you, what were you laughing at? Or any other number of questions. By saying never mind, you are telling that deaf person they are not important enough to have access to that information. And whether you mean it that way or not, it is incredibly insulting, especially when you do it repeatedly. Also, yelling at us, again, you look stupid. It does not matter how loud you are, we won't be able to hear you. And just because we can hear something does not mean our brain can understand what the sound is. Because some of us not only have hearing loss, but audio processing disorders in which the brain does not always process the sound. So there's multiple different forms of hearing loss.
In this video, we use the term deaf with a lowercase d as an umbrella term to describe those who identify as deaf with a capital D, deaf with a lowercase d, hard of hearing, late deafened, and deaf disabled. The term hearing will be used to describe individuals who do not identify as deaf, with a capital D, deaf with a lowercase d, hard of hearing, late deafened, or deaf disabled. While the term deaf with a lowercase d is often used by hearing people to denote an auditory medical condition, we use deaf with a capital D as an individual's identification with the deaf community, deaf culture, and the use of American Sign Language. The term autism refers to a form of prejudice, discrimination, or oppression that is directed toward individuals who are deaf or hard of hearing. And it's based on the assumption that hearing is superior to deafness. Autism can manifest in many forms, including assuming that deaf individuals are unable to lead successful and fulfilling lives. In contrast, the term deaf gain is a perspective that views deafness as a cultural asset rather than a deficit. It recognizes the value that the deaf community and its culture brings to society. This perspective challenges the dominant narrative and the dominant hearing-centric view that sees deafness as a problem that needs to be fixed. Instead, it recognizes the strengths and advantages that come with being part of the deaf community and being raised in deaf culture. Bridging cultural gaps between deaf patients and hearing medical providers requires a mutual understanding and respect for the perspectives and experiences of both groups. It is important for medical providers to understand that deaf individuals are not just patients with hearing loss, but members of a unique culture with their own languages and experiences.
So my name is Dallas Olney, and I am hard of hearing, but I also mostly label deaf because even though if my cochlear implant is on, it doesn't mean I can hear everything. I can hear about 60%, 70%, but I still can hear, but I can talk a lot. But I was growing up oral. And then I can do things that some deaf people can't do, but it doesn't mean I'm hearing and I'm so deaf. I like to label myself hard of hearing and deaf.
It is helpful for providers to understand the unique background and experiences of many of their deaf patients. Every individual should have the right to communicate, express themselves, and understand the world around them. However, for deaf and hard of hearing individuals, access to language can be a daily struggle. Deaf children of hearing parents often experience language deprivation from early childhood. Language deprivation in deaf and hard of hearing children is a delay in language development that occurs when sufficient access to language, either spoken or signed, is not provided. This denies the child of the ability to develop language and communication skills in the first few years of their life, often called the critical or sensitive period. The impact of language deprivation can be severe, causing low self-esteem, difficulty in forming relationships, difficulty in school, and limited job opportunities in the future. Deaf people also experience lack of incidental learning. Incidental learning occurs when we learn information without even realizing it just by being exposed to it in our environment. Deaf patients with hearing parents may not have equal access to information informally discussed or overheard in the home because of lack of access to spoken English. This is sometimes referred to as the dinner table syndrome. This may include lack of knowledge of family health history, important to understanding their own health risks, lack of information about health information communicated through informal conversations, lack of access to public service announcements on the radio and TV, and information about public health current events like the COVID-19 pandemic. Due to this lack of access, studies have shown deaf people tend to have decreased health literacy compared to hearing populations.
Okay. I don't feel like I had equal access to information. I needed more information so that I could have the same information as my hearing counterparts. We're all human beings and we all need to be together. And we all need to have the same information instead of leaving people out, like I sometimes was left out.
Health literacy is the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. All of these factors can lead to decreased health literacy in deaf populations. Deaf adults may have limited access to quality healthcare services, which can make it difficult for them to receive the care and information they need to maintain their health. For example, on-site interpreters are not usually available at vaccine clinics to answer questions about vaccine risk and benefit and combat misinformation. Lack of access to adequate communication services in healthcare settings can lead to misunderstandings, misdiagnosis, and a lack of trust in the healthcare system. Many health-related materials are not available in sign language or other accessible formats. Deaf patients may avoid seeking medical care or services. This phenomenon can be attributed to several factors, including communication barriers, negative past experiences, lack of access to information and resources, and cultural differences. Negative past experiences can also contribute to healthcare aversion in deaf populations. A bad experience with a healthcare provider who was unable to effectively communicate with them may cause reluctance to seek medical care in the future. These challenges can impact their ability to make informed decisions about their health and access appropriate medical care. Due to these factors, deaf persons experience many health disparities, including increased risk of cardiovascular disease, high blood pressure, diabetes, stroke, depression, and anxiety. As healthcare providers, educators, and organizations, we can work together to ensure that deaf adults have access to the information and support they need to maintain their health and well-being. Hearing individuals' lived experiences is really important to understanding these issues, so let's hear from some patients about their previous experiences in medical care.
Hi, my name is Ella, and I'm a rare disease patient, which is what caused my hearing loss. I was born hearing, and they found my hearing loss when I was in 3rd grade. That's also when I got hearing aids. And as I got older, I lost more hearing, which means that I was raised in a hearing world, and because of my rare disease, I grew up in medical settings. I also come from a medical family. My mother, my grandmother, they're both nurses. I have an aunt who used to ride the ambulance before she had 5 kids. And there's also other health problems in my family that have meant that I'm immersed in the medical world. Because I didn't learn sign language until high school, I never had interpreters growing up because I didn't know sign language was a thing. Now that I'm grown and I do use sign language interpreters for my college classes, I still elect not to use them in medical settings because I'm so comfortable there and I know about the policies for communication. When it comes to one person in the room with me, I'm generally fine because I have no distractions. As soon as you add a second person to the mix, it's a lot harder for me to keep track of conversations. When I have gone to the doctor's office, which is almost monthly because of my disease, it has led to some interesting conversations about how I prefer to communicate and why I don't want an interpreter. When COVID happened, because I speak so well, people often forget that I am deaf and I cannot hear what is happening even with my hearing aids. After about 3 months of going to monthly appointments during COVID, I gave up trying to talk to the MA and instead just wrote on my phone, "I'm deaf and here is all of my check-in information," which included things like my name, my address, my date of birth, everything they ask for in order to confirm for appointments. Then when they called me back, I would just watch the door and see if someone would look around after speaking. In all likelihood, they called my name and I didn't hear them. Then I would follow the nurse or the tech, whoever was doing vitals, to the back room. I would tell them, "I'm deaf, are you willing to lower your mask for me? We can stay as far apart as you want." Sometimes they would lower their mask and we'd have a small chat while we were doing vitals. Other times they'd shake their head no and we'd just sit there in silence. My doctors know me very well because of my rare disease, and most of them were quite willing to work with me despite my hearing loss during COVID and the requirements for masks. Some of them would just stand a couple of feet away from me and lower their mask and keep it down for the entirety of the appointment until they were doing some close-up checks. Other doctors refused and they just had to speak up a lot, which I really didn't like, but I was willing to put up with it.
Okay, one time back in 2021, a year after COVID, everyone decided to provide free vaccinations. I got the information about it through my mom. Otherwise, I wouldn't have ever known. Because I am deaf, the communication was not brought to me. I called the phone number for the local vaccine clinic. We worked it out over the phone, what time it would be and where. And then I said, make sure you get an interpreter. And they said that they would. But later, when I showed up on the day that I was supposed to, I was a little bit nervous, and I came to the front desk and I said, using my phone, that I'm deaf. And they read what I had to say. They showed me where to go, but I said, do you have an interpreter? In my text on my phone, I said, do you have an interpreter? And they said, no, we don't. And I thought to myself, I let you know about getting an interpreter, but you didn't. They said that they did finally find an interpreter, and that person showed up about 10 or 15 minutes. After I was supposed to get the test, I got the vaccine. After they asked me questions, I waited about 15 minutes. They wanted to make sure that I felt okay. And I left, and everything was fine. I went in for a booster shot, or for the second shot, and I did not have a good experience. The second experience was even worse than the first. They pulled in a hearing person to interpret for me that was not certified. I tried my best to navigate that situation like I did with the first. And luckily I had already experienced the vaccine, so I knew what was going on. And so it ended up being okay.
So my time during the COVID time, I have a hard time trying to understand the doctor because there was no interpreter there. And so during the time there was no interpreter, and the doctor tried to talk with me, but it's harder for me to understand them because they have their masks on and I cannot see their lips. And so they were just telling me what to do was to lift up and just put me everywhere. And I just become lost. And I don't know what I'm doing. I just follow the plan. Follow the flow.
Medical ethics dictate that patients understand their diagnosis and the risks and benefits of treatment so they can make informed healthcare decisions. In order to make informed medical decisions, patients need to have competency, capacity, and be free from coercion. This requires patients to be given health information in a way they can understand. Since many deaf patients use ASL as their primary language, some deaf individuals may have limited English proficiency. To bridge gaps in language comprehension, it is important to provide deaf patients with ASL interpretation services when requested to ensure informed consent. The Americans with Disabilities Act, or ADA, is a federal law that prohibits discrimination against individuals with disabilities, including deaf individuals. The ADA applies to a wide range of areas, including employment, housing, public accommodations, and telecommunications. In healthcare settings, the ADA requires that medical providers make reasonable accommodations to ensure equal access to medical services, information, and resources. This can include providing sign language interpreters, providing written materials in accessible formats, and using assistive technologies to facilitate communication and access to information. By complying with the ADA, healthcare providers and other organizations can help to ensure that deaf individuals have equal access to goods, services, and employment opportunities, and that they are able to fully participate in all aspects of society.
There are 3 main federal laws that apply to hospitals. The first is the Americans with Disabilities Act. The second is Section 504 of the Rehabilitation Act. And the third is the Affordable Care Act. There needs to be effective communication, and what that looks like depends on the patient and not what HR or the legal department or what the hospital thinks. You should have what they call an interactive process. Sit down with the patient and say, how does communication work for you? What does that look like for you? Do you need an ASL interpreter? Do you need video remote interpreting services? Do you need a cued interpreter? Do you need an oral interpreter? There are a lot of different ways to provide that. So under Title III of the ADA, even though the hospital gets to choose what effective communication will be, they really should talk to the patient and have an interactive discussion with them and find out what that effective communication looks like.
Let's talk about appropriate and inappropriate terms when referring to deaf persons. Deaf and hard of hearing people have the right to choose what they wish to be called, either as a group or on an individual basis. Overwhelmingly, deaf and hard of hearing people prefer to be called deaf or hard of hearing. There are many terms often seen in print, heard on radio and television, and picked up in casual conversations that are considered inappropriate within the deaf community. Hearing impaired is no longer an appropriate term because of the negative connotations of the word impaired. This term focuses on what people can't do and establishes the standard of hearing and anything different as impaired, substandard, hindered, or damaged. It implies that something is not as it should be and ought to be fixed if possible. The term deaf and dumb was originated by the Greek philosopher Aristotle, who believed that deaf individuals were not capable of being taught, learning, or thinking critically. Over time, the word dumb came to mean the word silent. However, this term is deeply offensive to deaf and hard of hearing individuals for several reasons. Deaf and hard of hearing individuals are not silent. They have various methods of communication, such as sign language, lip reading, vocalizations, and other forms. Communication is not restricted to only those who can hear, and using one's voice is not the only way to communicate effectively. The word dumb now also carries the connotation of being stupid, which has led to the belief that if someone can't use their voice well, they must be less intelligent. This is a baseless and discriminatory assumption. Deaf-mute is another offensive term. Mute also means silent and without voice. This label is technically inaccurate since deaf and hard of hearing people generally have functioning vocal cords. Again, because deaf and hard of hearing people use various methods of communication other than or in addition to using their voices, they are not truly mute. Let's talk about the term disability. Whether it is okay to refer to deafness as a disability depends on the context and the perspective of the individual being referred to. From a medical perspective, deafness can be considered a disability because it results in a significant hearing loss and can impact an individual's ability to access information and participate fully in society. In this context, using the term disability can be seen as a neutral or even empowering description that acknowledges the challenges faced by deaf individuals and the need for accommodations and support. However, many members of the deaf community see deafness not as a disability, but as a cultural identity and a unique experience of being deaf in a hearing-dominated world. For them, using the term disability can be stigmatizing and reinforce negative stereotypes and attitudes. In conclusion, it is important to be mindful of the perspective of the individual being referred to, and to use language that is respectful and appropriate in the context. If in doubt, it may be helpful to ask the individual how they prefer to be referred to or described. So now let's talk about the do's when it comes to referring to deaf individuals. Do find out how the patient self-identifies. Deaf and hard of hearing are not negative terms in the deaf community. Understand the term deaf with a capital D refers to more than an audiological condition. When it comes to patient autonomy and accommodations for deaf individuals, there are several important do's and don'ts to keep in mind. Don't rely on family members or untrained individuals for interpretation. Family members may not be familiar with medical terminology or may have their own biases and opinions, and untrained individuals may not be able to provide accurate interpretation. Don't assume that all deaf individuals use sign language. Not all deaf individuals use sign language, and it is important to ask the patient about their preferred mode of communication and to provide the necessary accommodations. Deaf individuals have the right to control their own healthcare decisions and to access the information and resources they need to make informed choices. Do respect the patient's preferred mode of communication. Some deaf individuals may prefer to use sign language, while others may prefer written communication or speech reading. It is important to respect the patient's preferred mode of communication and to provide the necessary accommodations to facilitate effective communication. Do provide qualified sign language interpreters when requested. Deaf individuals have the right to access accurate and complete information about their health and treatment options, and a sign language interpreter can help to facilitate communication and ensure understanding. Do use accessible materials and technologies. This can include providing written materials in large print or braille, using closed captioning or real-time captioning during virtual appointments, and using remote video interpreting services when in-person interpreters are not available. Do consider cultural differences. Deaf culture has its own unique traditions, values, and experiences, and it is important to be culturally sensitive and aware of these differences when working with deaf patients. Remember that providing the requested accommodation is imperative for the success of their health, regardless of the visit purpose, whether it's screening, procedures, well checks, sick visits, medication review, or other appointments. For most deaf people, ASL is their primary language, and for many, they have very limited proficiency in English, whether written or spoken. This means they're unable to communicate effectively without the use of an ASL interpreter. Thus, it is important to provide the accommodation of an ASL interpreter when requested. By following these do's and don'ts, healthcare providers can help to ensure that deaf individuals have equal access to healthcare services and to help support their autonomy and self-determination in their healthcare decisions. Now let's talk about getting a deaf patient's attention. First, the don'ts. Never physically try to move them around by grabbing their arm and pulling them around without permission. Don't stomp on the floor, bang on the table to get their attention, or flash the lights on and off when you're trying to get just one person's attention. Don't aggressively jab the person you want to talk to or wave your hand right in front of the person's face in close proximity. And definitely don't say it doesn't matter or it isn't a big deal if they didn't understand something. Do wave in the line of sight of the patient or lightly tap the patient. With an interpreter, don't talk directly to the interpreter. You're communicating with the deaf patient, so look at the patient when talking to them. And when the interpreter is talking back, continue to look at the patient. You may need to consciously train your brain not to look in the direction of the sound. Also, don't talk louder or slower. Do directly talk to your patient and make sure you have their attention before talking. The patient will need to be able to see the interpreter. Do maintain eye contact. ASL is a highly visual language. Don't look at your computer or fill out paperwork while talking or listening. This comes across as ignoring or just not listening to the patient. Do use normal lip movement and talk clearly and at a normal volume and pace. If the patient is lip reading, make sure the room is well lit. Do use written notes or diagrams to assist you if you're having difficulty explaining something. But remember that deaf people have different communication needs, so writing information down won't be helpful for everyone. If your patient doesn't understand you, try and think of a different way to explain yourself rather than repeating the same words again. Do use gestures and facial expressions to help explain yourself. Show with your face if something is painful, scary, or nothing to worry about. Do point to parts of your body if necessary. Do keep checking to make sure your patient understands you. If your patient doesn't understand you, try and think of a different way to explain yourself. Do have the interpreter stand behind the doctor instead of between, if possible. Still, you might encounter situations where you're waiting for an interpreter to show up, or at times when the VRI or video remote interpreting is not working and alternative accommodations are being arranged. Do let the deaf person take the lead on communication style before the interpreter arrives. Wait and see how they initiate or negotiate the communication. Let's look at some different communication scenarios. Don't expect patients to lip read. While some deaf and hard of hearing people are able to lip read, it isn't always the best. It's one of the least effective forms of communication. If they write something down and give it to you, don't respond in speech. Not everyone lip reads. Even the best lip readers miss quite a bit of communication. Even if a patient is comfortable lip reading, it's important to remember that only 30 to 40% of speech sounds can be lip read, even under the best conditions, and extra information is usually required to understand what is being said. Talking louder or slower does not help with lip reading and can come off as condescending. If your patient is comfortable with lip reading while waiting for an interpreter, speak normally, yet clearly. While lip reading should not be the only form of communication while working with deaf patients, allowing patients to see your mouth while speaking allows them to gather additional context, know when it is their turn to communicate, gauge tone, and use lip reading as supplemental information to the primary communication method chosen.
I am tired of having to constantly educate providers about my rights to communication as a patient. What is a reasonable accommodation to them may not be effective communication for me. It's exhausting and energy draining, and COVID-19 mask policies can make it impossible to lip read. And one person or no visitor policies make it really hard to have an on-site interpreter for those who need one. It's like they think it doesn't matter that I want access to full information. I dread medical appointments when that happens. I love when doctors are aware that I need to see faces to understand the emotions behind the message. One doctor was so flexible that he swapped his face mask for a clear mask.
Use lip reading as supplemental information, not the only source of information, and speak clearly and naturally using gestures and expressions to help convey meaning. Be willing to repeat or rephrase important information to ensure the patient has understood it correctly.
It's not important.
A few things went wrong in this scenario. First, try to avoid using shorthand or abbreviations. If writing physically, write clearly with your best handwriting to avoid misunderstandings. Don't say never mind or it doesn't matter. This is a breakdown in communication that can lead to health issues, incorrect prescription use, informed consent, and just a feeling of not being valued. Don't leave people out of the conversation. If you write or type with a deaf person, do not look down on their English skills. Remember that many deaf and hard of hearing people are deprived of language as children, and that English is a second language for many deaf people. When writing back and forth with a deaf patient, be willing to write and give them all the same communication in writing that you would give them verbally. This includes full sentences and using proper grammar. Look at the person during the written communication and have patience to finish the communication. Let's review some important things to keep in mind when communicating with deaf and hard of hearing patients before an interpreter arrives. Ask the patient about their preferred mode of communication and make accommodations as needed, such as providing sign language interpretation or visual aids. When writing, give them all the same communication that you would give them verbally. This means writing in full sentences, allowing time to write, looking at the person during the written communication, and staying engaged during the process. It's important to give additional context. This can include gesturing while speaking, demonstrating any actions needed, wearing a clear mask to ensure the patient can see your mouth, and never turning away from the person while communicating with them. Provide visual aids such as written materials, diagrams, and gestures to supplement verbal communication. Communicate with eye contact first and then type up notes on the computer if possible. Because sign language is a visual language, it may feel like they are not being listened to if you're looking at something else. Do not assume that deaf or hard of hearing patients cannot communicate effectively or that they do not understand what is being said. Remember to show empathy and understanding for the challenges faced by deaf and hard of hearing patients, and respect their preferred mode of communication. Be patient and allow extra time for communication, especially when using sign language interpretation or other accommodations. Many deaf people may not have access to information regarding COVID-19 due to the lack of accessibility. Be patient with those who might have concerns about vaccines. Patience and clear communication can help ease patient worries. Clear communication requires accommodations, so be sure to ask and follow through with providing the patient's preferred communication, typically an ASL interpreter, a certified deaf interpreter, or video remote interpreting. Sometimes patients will request video remote interpreting, also known as VRI. This can be a useful tool when on-site interpreters are unavailable or while waiting for an interpreter to arrive. It's important that all providers are competent in using VRI. This includes knowing where the device is located, understanding how to connect to remote interpreters, where to set it up in a room, and current device availability. VRI devices should be placed either between the patient and the provider or directly next to the provider, depending on the preference of the patient. Ensure the device's sound, video, and microphone settings are set to a comfortable level. Deaf patients have reported frustration with the video lagging and freezing, which impedes communication, especially when signing, so it's important to make sure there is a functioning high-speed internet connection. It's a huge relief when the medical professional is able to quickly set up the VRI connection. This shows competency in providing their accommodation. If possible, have it set up before the patient is in the room to reduce excess waiting and anxiety over lack of communication.
My worst experience of my life was not having an interpreter. How can that work? They do provide video remote interpreters sometimes, but that's challenging because the Wi-Fi connection and the breaks often. A live interpreter is much better. When I had my babies, I could not rely on my husband for communication. My mom is hearing, but I couldn't rely on her either. I needed a live person, a live interpreter there. But when my children were being born, they pulled in a video remote interpreter, a VRI. It is not the best. The best thing to do is to use a live interpreter.
VRI is a communication tool that utilizes interpreters remotely. It can be a potentially reliable source of communication for certain situations, but is problematic for others. When it is used, the internet connection needs to be reliable. A larger screen can help the patient better see the interpreter signing and minimize frustrations. Let's narrow down sight and sound to 4 things. 1. Accessing the environment. Someone has to share with the VRI interpreter what is happening off screen so they can relay the message appropriately. This includes nonverbal gestures like pointing to a specific area on the body or pointing at graphics. Second, the remote interpreter has to be able to clearly hear the person speaking at all times. This may require that the person speaking be close to the VRI system or have a mic system connected. The person speaking needs to enunciate the words clearly, including the diagnosis or medications. Third, the interpreter needs to know who is speaking at all times. Is it the doctor, a nurse, an intake staff, a cleaning crew, a family member, or otherwise? So remember to identify who you are each time you speak. Lastly, the lighting in the room and position of the BRI system in relation to the deaf person must be considered and worked through. It is important to check with the deaf individual if using VRI is an option they are willing to try before an on-site interpreter arrives. Ask the deaf patient if VRI is acceptable to them for that circumstance. Some patients feel VRI is an acceptable mode of communication for certain appointments, but unrealistic for others. For example, a patient might be okay with VRI for a quick COVID test, but not a life-threatening emergency or childbirth. If a deaf patient does not want to use VRI and prefers to pass notes or communicate in another way while waiting for the interpreter, respect that choice. In-person interpreters are usually preferred and minimize issues related to slow internet connection. When patients choose to have a live on-site interpreter, there are a few factors to consider in regard to your organization and state's COVID-19 procedures. Mask requirements have made effective communications between hearing providers and deaf patients more challenging for both lip reading and ASL for deaf patients. A preference for telemedicine during the COVID-19 pandemic can cause increased communication difficulties because ASL is a 3D language and key communications can be missed on a two-dimensional screen. Strict visitor restrictions in clinics and hospitals during the height of the COVID-19 pandemic limited access to on-site interpreters in some cases. As you assess the situation, remember to address the communication needs of the deaf patient. The patient's communication needs are a crucial factor in navigating all of the next steps, and this may require that one more body, the interpreter, be in the same room. Be sure to have a plan in place, reviewing and including state and federal requirements. Ensure all staff members understand what is allowed when it comes to using interpreters, wearing masks, and other factors necessary for effective communication. Communicating with the aid of an interpreter may be new for many providers and may feel strange at first. Here we will cover etiquette when communicating through an interpreter to help your clients feel acknowledged and respected. Let's take a look at some common mistakes.
For the COVID vaccine, I just have a few concerns. Are there side effects?
Tell him he might feel some muscle soreness, muscle aches, chills can be a side effect.
Okay. Any serious possibilities of side effects?
It is best to have the interpreter stand or sit next to the person who is talking, usually the doctor or nurse. This allows the deaf person to see the interpreter and the person speaking at the same time within their peripheral vision. If space doesn't allow for the interpreter and person speaking to be next to each other, ask the deaf person how they want everyone to be situated. This will help avoid confusion when the deaf person has to shift from one person to the other, as well as reducing the possibility of neck strain. Remember, when communicating with the patient, look directly at them, not the interpreter. Refer to the patient speaking directly to them, using terms such as you or your rather than tell him or tell her. When speaking, be sure to allow time for comprehension. Be patient for longer communication processes because interpreters need to interpret and make sure everyone is on the same page. Maintain direct eye contact with a patient and converse with him or her as you would normally with any other patient. It may feel odd because the deaf person is looking at the interpreter and not directly at you when you are speaking. You may be naturally inclined to look at the interpreter because they're the one verbalizing the message. But remember that it's the deaf patient that is actually speaking, not the interpreter. If you look at the interpreter, the deaf person may feel left out of the conversation because the focus is on the interpreter instead of on them and their health. Look at the deaf person and talk directly to them instead. If you need to type up notes on a computer, do so after communicating with eye contact if possible. The deaf individual may not feel listened to if you do not communicate with eye contact. Make sure you don't block nonverbal communication by turning your back or blocking line of sight. This can break trust because the deaf patient can't see facial expressions such as frustration or eye rolling. If you need to address someone else, you could gesture, "Hold on a minute," and turn your head so that the deaf patient can still see your profile.
I'm curious, with the COVID vaccination, are there any side effects?
You might feel some tiredness, muscle pain, aches, chills, nothing too serious.
Oh, okay, that's good to know.
Much better. In order for patients to have equal access to health information, deaf and hard of hearing patients need you to communicate clearly and naturally. When communicating through an interpreter, it is crucial to articulate your words clearly and at a regular pace to facilitate a smooth interpretation. It is important for doctors to explain prescription instructions to deaf people because they need to understand how to properly take their medication to ensure its effectiveness and avoid any adverse effects. By explaining the prescription instructions in a clear and concise manner, using gestures and visual aids if necessary, the doctor can help to ensure that the deaf patient understands how to properly take their medication. This can improve the patient's health outcomes and reduce the risk of negative consequences from incorrect medication usage. The interpreter is there to facilitate communication between you and the deaf person. It's important to respect their role. When speaking to the deaf person, it's important to make eye contact with them, not the interpreter. The interpreter is only there to interpret the conversation, and the deaf person should be the focus of the conversation. The interpreter is only there to interpret and will not be offended when you are looking at the deaf patient. When speaking, it's important to speak clearly and at a normal pace to make it easier for the interpreter. Avoid using technical language or slang, as this can make it more difficult for the interpreter. Wait for the interpreter to finish before speaking or responding. Interrupting the interpreter can disrupt the flow of the conversation. Ensure that you allow for additional time for the interpreter to deliver the message and for the patient to make comments as needed before you speak again. It is appropriate and part of the interpreting process for the interpreter to take time to explain new concepts. Give them time. Your patience is greatly appreciated. Talk at a normal pace with pauses between new concepts or new information to make sure the patient understands their diagnosis or any instructions. You do not need to stop completely and wait for the interpreter to give you the signal to proceed. Continue to talk until the interpreter asks you to wait, and then wait for their signal to proceed. Interpreting can be a complex and time-consuming process, so it's important to be patient and understanding. It's important to note that allowing the interpreter time to convey the message clearly falls under your ethics as a medical professional, helping the patient understand their diagnosis, risks, and benefits of treatment so they are able to make informed decisions about their health. If you have any concerns about the interpretation or the interpretation process, it's important to provide constructive feedback. The interpreter may also ask you for clarification of concepts or terms in order to convey them appropriately. Work with these requests. The interpreter's role is to be a tool to effectively communicate between both you and the deaf person. Generally speaking, interrupting or talking over signing is not encouraged. But remember, the interpreter also serves you, so feel free to ask the interpreter what's happening. This can help to improve the quality of the interpretation and ensure effective communication.
When I make eye contact with my deaf patients and don't look at my notes or the interpreter, I can really tell it makes my patients feel valued and heard. Talking directly to my patients rather than saying, tell him or tell her, helps minimize confusion as well.
When I have a deaf patient come in, I can already expect that I will spend a bit more time with them, which helps me feel less frustrated.
Three pieces of advice that I would give medical professionals for working with me or any deaf person that speaks very well is to keep in mind, just because we're speaking does not mean we can hear you. Do not turn away from us. It will not end well. We will miss out on information you are trying to give us. And legally, we are entitled to that information, especially when we are the patient. Another piece of advice I would have: if we ask you to speak up, we're not trying to be rude. We're trying to be involved in the conversation and be involved in our own healthcare, which every health provider should want a patient to be involved in their own healthcare. It's kind of what makes the whole system work. And lastly, it never hurts to learn a little bit of sign language. If you go on YouTube and just find things that say top 5 signs for medical providers, I know off the top of my head 3 different creators that can show you the sign for medicine, nurse, doctor, allergy, breathe, blood, pain. I think I said pain already. But those are the kinds of signs that you will use every single day, whether you are working ER, L&D, ICU, med-surg, it does not matter. You will use those every single day. Learn them. It will make your life so much easier.
Every time when we go to the doctor, we always let them know ahead of time so we can get a request of a live interpreter. And so with the live interpreter, help us so much so we can able to, for me and my deaf wife, so we can see the live person in both ways. But with the VR, which is the video relay interpreters on the iPad, and it's harder because they only just focus on the wife, but I cannot see what's going on because they only have a rule only focus on the patients. If my wife is in the hospital, I can't see or know what's happening with my wife.
I recommend all doctors or nurses that they bring in a live interpreter, especially for emergency rooms. A live interpreter is needed for any type of emergency situation. What if my husband broke his ankle? That did happen, and it was challenging. We need a live interpreter there. Video remote interpreters can be improved. That whole solution can be improved. It's not the best. I encourage all doctors to provide better visualization and to look people in the eyes and to reduce the amount of writing back and forth between the doctor and the patient. That's it.
We know that medical providers and staff strive to offer the very best care for their patients, regardless of language, age, race, ethnicity, and disability. Taking these simple steps shared in this video can improve quality of care and health outcomes for those you serve. Providing ways to effectively communicate with a deaf individual may require learning more about their needs, but as you do so, the outcome will be a high-quality experience and increased trust. As you provide services for people who are deaf or hard of hearing, remember to be flexible, considerate, and listen. Ask the deaf patient their communication preferences. When using VRI, include the best practices we shared in this video. Have a plan in place for serious situations, and include the deaf person in the process. When using an on-site interpreter, remember to engage with the deaf person, not the interpreter. As you can see, there is a lot to learn and incorporate, but as you implement these things, your efforts will be noticed and valued. We appreciate providers and staff for taking the time to learn about deaf culture and how to accommodate deaf patients in a medical setting. By putting these practices into action, you can make a positive difference in the lives of deaf individuals and help create a more inclusive and equitable healthcare system for all.